All right. Hey, good afternoon, everyone. I'm glad you have joined us over here. It's actually session number three. We are talking about leveraging RHC flexibility to expand specialty services, financial operations, and strategic considerations. The speakers, it's me. Oh, along with Wade Gallen from Stroughwater and Beth Van Glider from Ascension. And so we'll close today with a session focused on how rural health clinics can serve as a strategic platform for expanding specialty care access and supporting long term organizational growth. Now, recent regulatory changes have created opportunities for rural health clinics to expand beyond the traditional primary care models and support a broader specialty care delivery within communities. And within this session, Wade Gallen, Beth Van Glider, the Chief Operating Officer at Ascension St. Thomas Medical Partners, as well as myself, will explore how healthcare organizations can strategically leverage RHCs to expand specialty services while maintaining financial sustainability and operational expansion. This discussion will focus on how organizations can evaluate reimbursement implications, assess operational readiness, understand staffing and compliance considerations, and determine the right expansion strategy based on community need and organizational goals. So now I'm going to flip my hat from being the MC to actually being the moderator of this session. So thank you, everybody, for joining us. And Beth, I really want to start with you. Can you share what strategic challenges or opportunities led Ascension St. Thomas Medical Partners to begin exploring this redesignation options for these clinics?
Yeah, thanks, Amy. Thanks for having me. Good afternoon, everyone. Really quickly, Amy, maybe what I'll do is just give the group a little bit of an overview of who we are as a medical group here in Middle Tennessee. Ascension St. Thomas is a Catholic-based health system, part of Ascension nationally. St. Thomas is located in Middle Tennessee, really based out of Nashville. From a medical group perspective, we have about 135 and growing locations across Middle Tennessee into Southern Kentucky. We do a lot of outreach within those locations. Our medical group is made up primarily of about 250 hospital-based physicians and then about 450 ambulatory-based clinicians. That includes physicians, APPs, LCSWs, ambulatory pharmacists, and so on. About a third of our medical group is based in our heart service line. So we do everything from general cardiology to heart transplant, advanced heart failure. Another third is in the primary care space, which will be most relevant to this conversation today. And then we have a third in various other medicine and surgical specialties. As it relates specifically to some of what we're talking about today, I think it's important to note that we have 7 primary care clinics currently located in rural areas and about as many specialty clinics within those spaces too. And if you're familiar with Middle Tennessee, Nashville sort of sits in the center of that. We have rural health clinics that kind of go out to the western side of our geography and out to the eastern side of our geography. And so that's really where we've done a lot of this work. So coming back to your question, Amy, in terms of the strategic challenges or opportunities that led us to explore this, I think what everyone can probably relate to and is most common is just there are obviously ongoing and anticipated changes with payer landscape. And for us, we're facing increasing costs and balancing that with our Catholic mission and commitment to prioritize the poor and vulnerable population. And oftentimes, obviously, patients in these rural communities are the most vulnerable. We really recognize that it was really leading us to consider ways to continuously really explore options to maximize our reimbursement, lower our costs, and really continue to be able to offer the best services we could to our patients. And so it led us to really think about and I know we're going to talk about this a little bit, but how could something like rural health designation or provider-based designation support that work and continue to allow us to support our mission and our commitment to these rural communities.
Thank you for that. So, Wade, Beth came to you, had this project and this idea in mind and things like that. Can you help us understand, what were the key questions that needed to be answered when thinking about this provider-based RHC designation? And is that the only strategy that was looked at and evaluated? Can you help us understand how you approached that project?
Yeah, absolutely. So, as part of the initial discussions, we really wanted to understand what the situation was for Ascension St. Thomas Medical Partners. Where were the practices located? What types of care are being delivered in each of the practice settings? And would some sort of redesignation strategy make sense given all of the areas that Beth just mentioned, right? Expanding access to care, ensuring that we have a sustainable reimbursement model to provide these services in these communities. And so we really started with those basics. We looked at, what these practices were that we wanted to evaluate. There were several of them that were designated as freestanding practices, so fell under the medical group, but were not provider-based in any form or fashion. And so we really wanted to explore what might that new designation mean for the health system from a financial and operational perspective, as well as is it even feasible? And so some of the considerations we made were again looking at the types of care being delivered in those various practices, evaluating at a very high level some of those regulatory and operational considerations that would need to be made to implement some sort of designation change for those practices. We needed to look at the associated organizations that these clinics may be provider-based to. So which organizations would they then fall under? Should they transition to some sort of, whether it's provider-based clinic, provider-based rural health clinic, or some other designation. So we really went about evaluating that that overview and that structure. And a couple of other things to note from the project perspective, some of the outputs that we had were really around that educational piece on some of the requirements of these available clinic designations and what they might mean for the organization. So a very education heavy focus. And then really what we ended up providing and what Beth and I had many conversations around was a set of practice specific recommendations around their designation options and really having that emphasis be on the operational feasibility of those and the financial impact associated with those different designations. And so that leads to our first polling question here, which is how familiar are you with the clinic designation options available for your organization? We'll just give a couple seconds here for the results to come in for that. Okay, we'll just give a couple more seconds here for the poll come through. We're starting to see some trends here. All right, and we'll end the poll there. And so the results of this polling question indicate that there's roughly a just shy of a third that are very familiar with the designation options for their organization. A fair number, so greater than 50%, are somewhat familiar. And then the minority are not familiar with some of these designation options for their associated clinics. And so we're just going to briefly, or I'm going to briefly run through some of the high level basics that we evaluated within the context of this project, but that we also use when we're working with organizations to evaluate what might be available to them. And so I'm going to go over two high-level designations that we see for organizations that have clinics within their footprint and go over some of the key requirements of each. And then we'll pick up the conversation with what this looked like in practice for Ascension St. Thomas Medical Partners, and Beth and I can really chat a little bit about the experience that we had in evaluating these. And I want to make sure that we're all starting off on the same terminology platform. And so when we're referring to clinics, some of the strategies and designations that you can entertain if you have clinics as part of a larger organizational footprint are the idea of a provider-based clinic. What does this mean? This means that you need to have a clinic that is operated as an integrated department of a main provider. So this would be a rural hospital or a critical access hospital. That includes everything from financial and clinical integration to being held out to the public and other payers as a department of that main provider. So a patient needs to be aware when they're entering into an organization whether or not they're provider-based and which organization they're provider-based to. It needs to be very clear to a patient that they are in a provider-based clinic location. There are some additional requirements depending upon whether or not a provider-based clinic is on or off campus. There are some off-campus requirements that apply here in addition to the other requirements for provider-based clinic status. So you need to be under the ownership and control of the main provider, need to have the same frequency, intensity, and level of accountability in reporting relationship as any other hospital department. You typically need to be located within a 35-mile radius of the main provider. There is some flexibility here from an RHC perspective, but from a provider-based clinic that is not a rural health clinic, there is that requirement there. Demonstrating that you're serving the same population as the main provider and must be located in the same state, or if it's consistent with the laws of both states, it can be in adjacent states. And so there are a number of other applicable rules and regulations, and it's very important if you're considering some sort of provider-based clinic analysis that you go through those regulatory requirements. But you want to make sure you're being compliant there. And really, when we're talking about some of the additional requirements for off-campus locations, it's really to make sure that these are truly integrated into the main provider, that we're not just claiming that they are, so we can proceed with a different reimbursement structure. So that's provider-based clinic. For a rural health clinic, which can also be a provider-based clinic, what an RHC needs to be is a public, nonprofit, or for-profit healthcare entity. There are some requirements that need to be met in order to obtain this. Most notably, you have to be located in a rural area and a designated shortage area. We're going to go over very briefly what that means here. But you have a number of other requirements of additional note, because I don't just want to read them all off, but you need to have an advanced practice provider footprint in that clinic. So there needs to be at least a 50% availability of those advanced practice providers in that clinic. Obviously, compliance with federal, state, and local laws, primarily engaged in providing outpatient health services, and you need to provide primary care services as part of that clinic. Appropriate patient care policies consistent with applicable laws. And again, a number of other requirements here. I do note the CFR reference or Code of Federal Regulations reference there at the very bottom. So if you're curious and looking into any of these requirements in greater detail, I would recommend that you go to the Code of Federal Regulations that is noted in that last bullet point. But these are some of the basic requirements for a rural health clinic designation. And so a provider-based rural health clinic is an RHC that also meets the applicable criteria for provider-based status. And again, just because I know I mentioned at the beginning here from a rural health clinic perspective that you have to be in a rural area and a designated shortage area, this provides some additional clarity around what is meant by rural. And so the term rural is utilized through the Census Bureau, the U.S. Census Bureau, and the Office of Management and Budget. So they really define what a rural community means. In the current criteria for a rural community, you need to not be in an urban area, which is noted here at the bottom, is an area with at least 2,000 housing units or a population of at least 5,000. So that's an urban area that's considered by the census. So if you're not in one of those areas, you would not be considered in an urban area. And then the last one, just again, high level here, you have a shortage area designation that applies if you are seeking rural health clinic status. So this would be a health professional shortage area, or a HPSA for short, which are designated as having a shortage of primary care, dental care, or mental health providers within a geographic area, population, or facility. For a primary care HPSA, which is what we look at for RHC designation in particular, there's a physician to population ratio of 1 to 3,500, and then 1 to 3,000 if there are unusually high needs. And then for a medically underserved area, this is another designation that can be used as you're thinking about RHC status to qualify as a medically underserved area, or a MUA. You have to operate in an area with an index of medical underservice, or IMU, rating of 62 or less on a scale from 0 to 100. This information will be sent out as part of the slide deck. I don't want to go into all of the details at this point, but just know that there are requirements if you want to pursue RHC designation, and it's important to understand those requirements prior to jumping in to any discussion around clinic designations. And so with that, just to make sure that we're all starting off on the same footing from a definition perspective, we wanted to go over that quickly.
Thanks, Wade. So if our audience, many of whom are evaluating similar opportunities, can you walk us through? I know you talked about the different types of clinics that are out there and things like that. Can you walk us through the different types of the freestanding model, the reimbursement differences, and what that all-inclusive methodology, all-inclusive rate methodology is, and help us to understand that?
Yeah, absolutely, Amy. And I think that this is a big consideration for any organization that's considering their clinic designations. So as a freestanding clinic, this would be a clinic that's not provider-based in any way. You're reimbursed by Medicare according to the fee schedule. So you get a set payment on a per visit basis. And many other Medicaid programs also follow suit for that designated clinic. As a provider-based clinic, from a Medicare perspective, you are reimbursed based upon a facility component and a professional component. So there is this split billing that occurs for provider-based clinics. So you receive a technical reimbursement amount as well as that professional reimbursement amount. And then for a rural health clinic, you're reimbursed based upon a cost per visit up to a certain payment limit that is set by Medicare. And this will vary depending upon the type of RHC that you are. There are differences even within the RHC designation for a clinic. So depending upon how long you've been operating as an RHC, you may have a different payment limit than another RHC. But generally speaking, you are reimbursed on a cost basis from Medicare up to a certain limit that is based upon your unique clinic. And so those are some of the reimbursement differences. And even as we think about the analysis that we did in this case, that was one of the driving discussion points, is really the analysis of what would this look like if we have a number of clinics that are considered freestanding at the moment. What would that financial impact be if we were to consider moving to a provider-based clinic or a provider-based rural health clinic type designation, assuming that those are feasible given all the requirements that we laid out. So it's really the path we took, and those are some of the things that we explore from a financial perspective when looking at those designations.
So when you were doing the modeling, did you model each clinic individually, and were there any that stood out as part of that modeling and, from your perspective and the information you pulled?
Yeah, so I can affirm that we definitely ran a different model for each clinic because each of them had a different cost structure so we had unique cost structures within each of the clinics, and so that warranted a review of the financial impact on a per clinic basis. Regarding whether or not there are any surprises, I don't recall there being much in the way of surprising findings. However, what I thought was very interesting, and Beth can kind of share more about this, is we looked at clinics with different services that were included within them in their footprint. So different providers, different locations, and so that all kind of played into that calculation on a per clinic basis as to what that financial impact might look like. So again, I don't know if surprising would be the right way to put it, but I found it to be very interesting to be able to look at the
Yeah.
differences between, say, a women's health clinic or a primary care clinic, to consider the nuances of even clinics with some specialty services within them. So it
Hmm.
was a very interesting exercise. And I
So
don't know, Beth. Oh, sorry, go ahead, Amy.
I was going to say very similar to what you said before in your earlier presentation. When you've seen one critical access hospital, you've seen one critical access hospital. So when you were
Yeah,
doing this analysis, it wasn't just, hey, here's a cookie cutter cut and paste, and it was really modeling it for each of those
mm,
individual clinics. And so,
yeah.
then you were going to ask Beth a question. Sorry for interrupting.
Oh, no, not at all. I was curious if Beth had any surprises based on that financial impact analysis we did, or anything in the process that surprised her.
Again, I don't know that I was surprised as much as just not having a lot of expectation going in and sort of, having a very high level understanding of the differences that Wade just described. I think I would just emphasize the fact that this was more of us saying, here are the practices we have, the clinics we have that are in these rural health areas that we know likely qualify for something, could be designated, redesignated, and we sort of didn't put our own expectations around it and sort of handed it over. I think that was really important because we started to realize how, from a financial perspective, for instance, a practice that was a certain specialty in that space, their payer mix was so vastly different from some of the others. It didn't really make sense to go through the administrative burden. And, we'll talk about this, I'm sure, but there's a lot that goes into converting these practices to not just being a freestanding clinic. And so in some instances, it just didn't really make a lot of sense for us. And in others, depending on, as Wade pointed out, the specialty mix, whether it was primary care by itself, women's health, a combination, even in some instances. So I don't think it was surprising, but I learned a lot about how those things might impact future, choices about how we might go about this.
So there was no, and probably wrong word, but there was like no buyer's remorse. Like we had our plans set that this clinic was going to become our HC designation. You went into it with an open slate saying, here
Yeah.
are our clinics. Tell us what the best use of these clinics is, then the most advantageous choice versus we really had our heart set on, this was the clinic. It was going to become this, and here's how we were going to do it. That's good advice to have to walk into
Yeah, I
think
mean, you don't have much to lose by just saying, here it is, tell me what you think,
yeah,
analyze this. So,
yeah.
yeah,
Give me back some data so that I can
Yeah.
make my plan.
that's
But
right. Yeah.
so okay, so Wade's done this data. He's giving you back the analysis now. What operational changes did you have to then approach to do that? If you get it back and you had no plan, and now it's like, oh, what do we do now?
Yeah. I would say that that was also kind of the biggest learning curve to some degree, right? Was he just walked through, there's a lot of requirements to convert these or redesignate them, for instance, to provider-based rural health clinics, right? And so, operationally, you have to start thinking through, okay, how are you going to bill the claims? You have to get, if you're tied to this facility. Early on, we realized that the tax ID for that particular facility, all of the payer contracts that they had didn't have a professional fee schedule component to them because that's not
Nope.
what they were written for. So I would say that was a huge lesson learned was, a lot of these provider-based clinics in our East Upper Cumberland region are tied to our River Park Hospital in McMinnville. And so when it came time to start changing enrollment, and we knew we needed to reach out to the payers, for instance, we realized like on the commercial or the Medicare Advantage side, they didn't have fee schedules for that. And so that was something that we had to sort of start from scratch. I think also really kind of understanding the impact to just the regulatory requirements, which Wade mentioned, And, we were lucky enough, having done a few of these a few years ago, that we had some resources we could return to. But Stroudwater was a part of that a few years ago too. I, I wouldn't guess that's the other thing I would say is don't guess whether you're going to meet that requirement or not. If you're unsure, find somebody who can really help you walk through that. We use, for our surveys and our compliance readiness, we use another vendor to do that. And they were incredibly helpful in helping us kind of walk through and make sure we were meeting all of the requirements. From a provider-based clinic perspective, I would say that is a heavy lift compared to being in a freestanding practice because now you're surveyable by Joint Commission. That comes with its own set. Wade mentioned, you have to have that reporting up to the hospital. So again, a lot of this we've leaned on you all, either historically or recently, to sort of help us make sure we're, dotting those I's and crossing those T's so we weren't creating any unintended consequences for our facilities. So I think operationally that's big. The one other thing I would just mention too is one of our big wins in the provider-based clinic space. We call them HOPDs. So that's the other, layman's term for that. We do have a way to leverage our existing EHR system. So at St. Thomas Medical Partners, we use Athena for both our EHR and our practice management system. And they do have the capability for us to split the bills out on the back end so that for the provider-based practices, we're able to bill both the professional fee and the facility fee without the system having, you aren't doing double registration, patients aren't getting two separate bills. We had the ability to do that. That was a huge win for us to work with our EHR vendor and figure out how to do that. So that's one thing I would comment on, Amy.
So were you able to keep your same existing staff? So staff stayed the same. It's just that organizational policy setup,
Yeah.
procedures, and it was more the administrative side as opposed to more of an administrative change as opposed to an operational change, right?
Yeah, that's right. The vast majority of it was like, just working with our hospital partners on making sure their policies and procedures became our policies and procedures. Because we're a fairly large integrated health system, a lot of that we shared anyway. But there's a lot of things that you do differently in a medical
Right.
group that you do in the hospital. And so that's where we needed their help. We had, their survey readiness team come out and do their own walkthrough and survey with us to make sure that we were meeting. Here's one of my favorite stories is we did a provider-based clinic redesignation, and facilities came through, and all of our sharps containers were like 3 inches too high on the wall, and we had to lower them. So it's just things
Right.
like that you don't think about. And if, we're thinking, how could it possibly be too high? Isn't that better than too low? And so, but yeah, I think to answer, from if you walked in today and talked to the staff about do they feel any different? I think their answer would be no. Their operation, the way they function is the same. There might have been some slight tweaking we had to do in terms of, some of the work that a physician does being designated to an MA versus somebody who's licensed. We had to
Mhm.
navigate some of those things. But yeah, for the most part, their operations have stayed primarily the same.
Were there any blind spots that you walked into or you felt like, oh, we should have paid attention to this and we just totally missed it? Or, looking back on that now?
I think what I mentioned earlier about just the payers, making sure all that was lined up, it took a little longer to navigate that with the payers in Tennessee than we anticipated. So that's just,
Payers
one
in
thing.
general.
Yeah, it was a little longer than we anticipated. Um, no, I think, and then just because we're doing some more of these, right? We're getting ready to do
Yep.
another analysis, and we've done enough, and we're going to do some more rural health designations. And so we've learned these incredible lessons about like, again, have facilities come out and walk through with you early on so that you're already preparing for what this looks like. But I think other than that, I don't really think there was a lot of places where we felt blindsided so much as just it was a great opportunity for us to educate our teams
Mhm.
and learn from some of those things I've already mentioned.
So you mentioned that we're working on another project with you now, but I remember as part of the initial analysis, there was this day that you sent an email that said, "Hey, I know we finished this first analysis, but as part of that, can you add these three other locations that hadn't been in consideration?" Can you give us a little background as to like what happened from a strategic viewpoint that really it was like, oh, while we're here, let's just bring these in into the conversation.
Yeah, I think initially, and maybe this is a little bit of a modification to an earlier answer I gave you in a question you asked. I think initially we did go in with like rural health, provider-based rural health designation for primary care. And there had been some changes to the requirements around primary care in that designation. And so that's kind of where our initial focus was. But when you all did the analysis, you came back and said, well, it might not be great for rural health, but it could be good for just provider-based designation. And that's really, I think, then once we got through that first round, we have a women's health clinic, we have a general surgery clinic, we have a heart clinic out in some of these areas. And so we thought, well, maybe we should reconsider not rural health designation for these, but provider-based designation. And so that was sort of what prompted it. And I think also just, we've kind of touched on like the financial pieces of this. Again, there's so much changing under our feet across the payer landscape, the legislative landscape, the federal government. And so we're really, even at an ascension level, our priority has become how do we continue to optimize the payment structures that are available to us so we can continue to support these communities because it's so core to our mission and core to who we are. And so we have a directed payment program or DPP program here in Tennessee, and that is really intended to help you take care of, that underinsured Medicaid population. And so knowing that that was available to us and it could help sustain, I mentioned to you earlier, 2/3 of our medical group is specialty. It's not
Mhm.
primary care. And so we already do a lot of outreach out of those 135 locations I mentioned earlier. Roughly 60 of them are outreach specialty locations. We go all over the place. And so for us, it's a really important part of our overall strategy, again, to give access to those communities where we're not asking them to drive 2 hours into Nashville or to Murfreesboro. And so part of it too, Amy, to answer your question was looking across at those clinics, the specialties that they were offering, the populations we were already serving, and how could
Mhm.
we maximize that. So with DPP and 340B, frankly, we were able, that also led us to kind of take a step back and look a little more broadly.
Yeah. So, Wade, she mentioned 340B. Can you give us just a highlight of what the opportunity was? I know it's still in flux. A lot of things are happening with 340B right now, but can you share a little bit from the financial side what you were looking at and how that was brought into the picture?
Yeah, absolutely. And I want to echo the point you just made that the 340B program is changing rapidly. There are many different factors right now for rural organizations that are at least are leveraging 340B or may have the potential to leverage 340B. So I would just say that there is a lot of change that is occurring right now. But what we did as part of this project was look at what redesignation could mean in terms of eligibility for those clinics as child sites of 340B designated organizations. So for critical access hospitals, they are designated as organizations that qualify for 340B. If you're a rural PPS hospital, you have to maintain a certain disproportionate share hospital percentage in order to qualify for 340B discounts on drugs that are purchased. And so one of the things we looked at was what would that potential impact be if we were to redesignate these freestanding clinics that were not child sites of any 340B qualifying organizations, them becoming those child sites as a provider-based organization, and what might that do to enhance access to 340B for the organization? There are many nuances to the 340B program, so I don't want to say that it is So this was a high level look at that optimization structure for the organization, but there are many nuances embedded within the 340B program. If you are a 340B eligible organization and the redesignation of your clinics, there's a strong interplay there between their designation and leveraging of the 340B program to gain access to those discounts, because we, as rural organizations, really need to be trying to leverage as many opportunities as we can to maintain sustainable margins and offer that care to our rural communities, as Beth mentioned. So that was, again, really a high level look we did to see if we redesignated these clinics as provider based and them becoming child sites of 340B eligible organizations, how that might impact things from a financial perspective.
Mm-hmm. And were there any other areas that you highlighted as part of the review that you look at? So I'm thinking, I don't necessarily know all the areas that you touch as part of this financial analysis. So you're looking at the 340B side. Or do you also look at like a payer complement and things like that and how that impacts the
Yeah, I think the payer component of this all is incredibly important for the financial impact. So, as I mentioned before, Medicare has ways that they reimburse clinics depending upon their designation. So, an RHC would be reimbursed very differently from a freestanding health clinic or even a provider-based clinic that doesn't also have the RHC designation associated with it. And so Medicare has those nuances, but we also have to be mindful of Medicaid and the way that the Medicaid program in each state, which is going to be a little bit different, right? So there's no one size fits all approach to this, but Medicaid may look at a clinic designation and reimburse a little bit differently than they would if you had not gone through with that designation change. And so a huge part of it is looking at those implications from a Medicaid perspective as well. As Beth mentioned, there are sometimes additional Medicaid related programs within a state that could be impacted by your clinic footprint and whether those clinics are provider based to an organization. So to your point, Amy, there's really a number of nuances to these types of evaluations. And what we find to be most helpful is really getting as much of a comprehensive view on that impact as we can, being
clinics?
mindful of things like payer mix, right? What is the mix of Medicare and Medicaid within the clinic? We have 340B and the associated differences there. We also have these kind of other supplemental payments that may be impacted by this. And so it's really important, I would say, and I think Beth covered it very well, and we would certainly recommend it for other organizations looking at your clinic strategy to try and take the entire picture as best as you can to know, does this make sense for our organization?
We did have a question that came in and just said, when considering adding specialty to RHC, how are the office procedures handled? Don't you lose the ability to bill separately for procedures with the RHC rate? And I know that you can bill those ancillary charges, then become part of the hospital charges. So they're billing for that technical component piece of it, that those ancillary services. But when you have multiple provider services, do you build that into the model that you consider as part of it?
Yeah, so that's a great nuance, and this gets into what types of services are we offering in our clinic, and does that make it conducive to something like a rural health clinic designation where there because of the reimbursement mechanism, right? So for Medicare, we kind of have this cost-based reimbursement up to a payment limit, and then we have visits that qualify as an RHC visit versus certain procedures that might not qualify as a qualifying visit for RHC purposes. So there are different, even within that RHC designation, there are reimbursement nuances, and that's something that we try and be very mindful of as we're approaching these designation evaluations. And so I think that's a great point. Depending upon the specialty and the ratio of that specialty in a clinic, something like a rural health clinic designation may not make sense or even be viable and feasible for the organization.
So Beth, how did the provider mix? You mentioned that some of the services had to, the providers are handing that off. How did it influence, the initial transition, but then long-term sustainability? Are you finding that you have workforce challenges, or how is that leading there?
No, I don't think we have any workforce challenges at all. I think the physicians and the APPs that have been in place have, they already have a strong commitment to serving the community. They chose to be in rural clinics to begin with. So, they're, I think, very supportive of whatever we can do to help continue to offer those services. You look across the country and other places are shutting down rural hospitals. There's complete deserts where you don't have access to any care. We have counties like that around Tennessee too,
Hmm.
right? Where sometimes we're the only source of care on a very, small scale. So I don't think we've had that at all. And I think, really it also kind of has allowed us to continue our desire to grow our care team models or implement some where maybe we didn't have them before. So we, as opposed to just looking at a physician and an APP in a traditional practice, we also, I mentioned earlier, we have LCSW, so we're trying to support the behavioral health component. We have CHWs, community health workers, that are a part of this as well. And so a lot of this for us has just been, anything I think that the providers see as an opportunity for us to extend the care and the services they're able to offer to their patients, they see as a positive. And so that has actually gone quite well.
And we actually had another question come in that just asked if you have seen an increase in quality and patient satisfaction as part of the change, or is it purely just a strategic change that's happened in the background?
I think probably what I just mentioned, I would say in terms of the quality of care or the quality of services we're able to offer our patients. So we might have had some of those services in place prior to this, but now we're able to make sure that they're sustainable. I mentioned earlier, we also have ambulatory pharmacists that work with a lot of our primary care practices and now moving into the specialty space. We're lucky in the state of Tennessee that some of the services they provide in the ambulatory space are reimbursable outside of being incident to what the physician does. That's not the case everywhere. I think Tennessee was one of the first states to adopt that, starting to expand. But this is a way to sustain a care team member that you might not be getting that direct fee for service reimbursement that Wade mentioned earlier. It allows us to actually offer those services. So I think that I hope what the patients are seeing, this isn't something we've measured, but I hope what they're seeing is this, either sustained or increase in the quality of services and the number of services that they're able to get from us in those locations.
That's great to hear. So we are getting close to just getting close to time, and wanted to leave it open for anyone that had any Q&A. So if you have any questions, feel free to drop it in the box. But as we wait for those questions to come through, Wade has a polling
Yep.
question. So Wade,
We
let's
we
fire that
sure
one
do.
off. All right.
We sure do. So if you have gone through the process of redesignating a clinic, what was the biggest challenge that you found? So billing setup, staff education, the accreditation process, project management, or some other challenge. Um, this will be very interesting to see what our attendees have noted as challenges. So we'll keep this question open a few seconds longer, see if we can get a good bit more participation.
Not entirely surprised by the answers, given I gave similar answers earlier.
And it warms my heart that
Absolutely.
people actually think about it. So
Yeah,
Yeah,
yeah.
absolutely. Um, well, we can close out the poll here. And for those that are interested, roughly 43% said billing setup was the most significant challenge for the redesignation process. And that was followed by the accreditation process. And then we had staff education, project management, and other were labeled there as challenges as well. But billing setup and the accreditation process. And Beth, it sounds like that might ring true with your experience.
Yeah, yeah, I think so.
And, we had a comment come through just now that said that they chose other, but it was trying to get the payers to switch to paying that RHC rate when switching from a PPS to an RHC. And that, when I say it's near and dear to my heart, that's what I work with, RHCs all the time, and just understanding what the billing setup is, but then working with those payers to help them understand that this is the designation and here's the all-inclusive rate, and you need to be paying us that all-inclusive rate, no longer paying us on the professional fee schedule, having those conversations. So what piece of advice as we get to this last part of it for both of you, I just would like to spend some time just asking, if clinics are exploring these redesignation strategies, what's the one piece of advice that you would offer? Wade, I'll go with you, and then Beth, let you close it from experience from your side.
Yeah, I think one of the pieces of input I would give, being primarily on that evaluation side of, financial and operational feasibility, would be, measure multiple times before you begin to cut, so to speak. So really go through the analysis. Don't try and shortcut anything as you're evaluating, whether a certain designation would make sense for your clinics. I think that there are important nuances that need to be understood, and as well the potential impact from a patient perspective as well. So I think there are just a host of factors. So I would say certainly make sure you are measuring. I wouldn't even say measure twice. I'd say measure 3, 4, 5 times before you start proceeding in a given direction, and really ask the questions of whoever is helping you through that process. Don't be afraid to ask questions, and ask as many as you can. So that's my thoughts. What about you, Beth?
At first, I would echo that ask all of the questions. You all have been incredibly patient with us and kind as we have asked a lot of very detailed questions. Or, if you pull this lever, how does it change this over here? And so I think, I mentioned this early on, but really having the ability to work with somebody who can really help you with that in-depth analysis. We had a couple of folks who thought, oh, they could take a run at this and see what they thought the financial impact would be, and it was not as accurate as what I think we developed with you all. And I think it really pays off to have a subject matter expert who understands the requirements and the impacts of things. Also, early on, Wade, you mentioned, there's a lot of ground shifting as it relates to something like 340B. So I think, part of what our journey has looked like is also talking about the long term. So let's assume 340B goes away. Is this still, the right thing for us to do? So we're also, I think, really trying to anticipate as much as we can, some of the impending changes that might start coming through. And I think, also just take the time to really make sure this is the right move, because it is a big commitment. You are going through a pretty heavy lift administratively, and you've got to educate your patients, and we had to change signage. There's things that there's a cost to, you're investing a little bit in making these changes, and you want to make sure it's the right thing to do for your organization for the right reasons. And then the last thing, if I could just share this, it's a little off your question, Amy, about lessons learned, but one of the things I'm also really excited about is that we have had a mobile health unit that has been sitting sort of dormant for the last few years, and we're actually getting ready to start the process to get rural health designation for that mobile health unit, so that we can take it out and really dive deep into some of these communities again where there is definitely a healthcare desert. And so I think also get creative about what do the communities you're serving really need, and what are your options or opportunities to really give back and contribute in a way that is meaningful to the community and sustainable from a financial perspective. So we're really excited about that kind of being another next step in our journey too.
Yep.
Yeah, that if I could just comment on that, Beth, because I think that that's an excellent observation and point around the kind of creativity piece, right? So we're facing all of these challenges in rural health right now, rural hospitals, rural clinics, reimbursement challenges, high costs, and kind of the reimbursement doesn't always keep pace with that. There are a whole host of, how do we manage our patient populations? And I think there is that aspect of, as you're thinking through designations for your organization and associated clinics, really important. We have to sometimes think a little bit outside the box as to how can we face these challenges that are coming our way. So I really appreciate you sharing that component.
Yeah. And so we have had a few questions come in, and we've got about 5 more minutes to answer that. So, Beth, the question sort of goes back to that contracting piece of it, an element. When you were going through the contracting, did you have any payers that pushed back, that didn't want to pay that all-inclusive rate? Or did they give you an excuse as why? And then how did you counter that? Or were you able to counter that?
So admittedly, we have a managed care team that handled a lot of those direct conversations, lucky for me. I don't recall them really pushing back so much as it just they weren't eager to go very quick in the process, I think is really. So maybe they sort of subconsciously pushed back, or maybe not subconsciously, but passive aggressively. So I don't think they really pushed back on it. And I think we were able to navigate those conversations. But again, I'm not the one who's necessarily handling those direct conversations with them, but we were able to get it done. So I know we were able to navigate, whatever challenges sort of came across. I think it was more a timing issue for us.
I would say that. And then from my perspective in dealing with payers and working with them to help them understand that it is a CMS designation,
That's right.
that rural health clinic, here's the CMS designation. You can take that back to the, CFR, the 42 CFR, and say, here's where it is. Here are the Medicare billing guidelines, and really counter it in that piece of it. And I would say, if you going back to the question with working through it, it may be that you need to go back to the drawing table and get your contract updated to truly reflect that they need to be
Yeah.
paying that all-inclusive rate.
Yeah.
Otherwise,
And
they're
that is
going,
what we had to do for sure. We definitely had to get our contracts updated, which I think is what led to a lot of the, delay in getting it done.
right. And did you move forward without that being in did you move forward without that being in place with the patients and just waited, or did you hold the project?
We moved forward just because it's very difficult to get all those to line up exactly at the same time. So we sat down with the, hospital leadership and said, okay, here's where we are. Here's where you'll be getting paid the appropriate rate. Here's where we're probably going to lose some ground on this for a little while. And they were because of the long-term gain and the long-term strategic vision, they were okay with that. But it's something we met about on a regular basis and just kept them updated on sort of where we were with everything.
Mm-hmm. Yeah, and really helping the payers to understand that, using the clinic's RHC rate, not referring back to a fee schedule, but really coming back to that piece
Yeah.
of it. Another question came in on how to get the patients to understand why they're paying more for an RHC visit. That's related to that copay, where the copay is calculated as 20% of total charges, not based on the allowable fee schedule. Did you all have conversations with patients? Have you changed fee structures? How did you all approach that?
Really, I think we developed talking points for our staff to use if they had to walk a patient through a change. A lot of it really revolved around, kind of that earlier question about our ability to offer and sustain services. And this was a way that we could ensure that we were able to do this. I don't have the talking points in front of me, but really trying to keep it at a very basic level with them, that they might see some changes in the way that their bill looked or the rate, but that we were trying to help minimize that for them and ensure that we were offering the best services and the highest quality care we could within the community.
And it could too be, another option to that is to really go back and look at your charge master again to help understand how much are you charging for this, because you are now under this different reimbursement model. Maybe we need to go back and visit that, because from a reimbursement perspective, you may have more money falling to your bottom line, but that contractual allowance piece of it, there is an art and a science around that piece of it as well. If I could just
Yeah,
say from a revenue cycle
that's right.
perspective and looking at your charge master and what are you charging and understanding what that impact is to your community as well as your patient mix. It could be your patient population is dual eligible, so there is
Yeah,
that side of it as well.
I was going to say it was probably less impactful in these communities than it would be if you had a similar situation and some that were more commercially driven because they're going to
Mm-hmm.
maybe perhaps notice it more. But you're right. I think given the cohort of patients and the demographic, it was a little different because they're oftentimes not responsible for the out of pocket.
Yeah. So, with that, I want to say thank you very much, Wade and Beth, for just joining in the conversation today. There is the contact information for both myself and Wade. We figure if you have any questions for Beth directly, feel free to put them through the Q&A. We will get them to her to be answered, or you can send us a note, and we can make that introduction for you. But just want to say thank you very much. And I'm going to put on my MC hat now. So that does conclude day 2 of the 2026 CA Virtual Conference. Thank you very much for joining all of the conversations today around service line development, swing bed strategy, and expanding the specialty care access to rural health clinics. Across today's sessions, we heard practical examples of how rural hospitals are evaluating growth opportunity, strengthening operational performance, and building care delivery models designed to better serve their communities over the long term. As a reminder, when you do close out of today's session, you'll receive that brief pop-up survey. We truly appreciate your feedback. It should take less than 1 minute to complete. We hope you'll join us again tomorrow as we continue the conference with additional sessions focused on practical, implementable strategies for rural healthcare leaders. Thank you again, and we will see you tomorrow.